Okay.
Yep, ready to start? Okay, excellent. I'm coming through there. All right. Anyway, welcome everyone to today's Impact Seminar series. I have the great pleasure of introducing Dr. Tess Reynolds. And Tess is the Deputy Director of the ImageX Institute, also a Robinson Fellow, and Cancer Institute of New South Wales Early Career Fellow at the University of Sydney. Through her academic industry healthcare partnerships with the University of Sydney, Siemens Healthineers, and Johns Hopkins University and Westmead Hospital, she's working to develop new technologies to deliver the future of interventional imaging in challenging surgical scenarios. In 2022, she received the Australian Museum Eureka Prize for Outstanding Early Career Researcher. So well done for that, Tess. Very impressive. So without further ado, over to you for your presentation. Thank you very much.
Thanks so much, Marcus, and thank you so much to the Impact team for inviting me to speak today. It's a real honour, and hopefully you can enjoy the ride. So definitely feel free to ask any questions as we're going along, but there should be some, hopefully, time for discussion at the end. I have crammed a lot in here because there's been a lot going on. So again, hopefully it is enjoyable. So start off just with the standard disclosures and disclaimers, but that's nothing too new. I also thought I'd just give a little bit of context about myself. There's plenty of people on this call that I don't know and that probably don't know who I am. So I can pretty much be boiled down to two things. One is my research. So I'm extremely passionate about what I do and I love having fun whilst doing it. So here are just some of the photos in the last sort of 12 months of being active. So up the top there is over in our hybrid theatre at Charles Perkins Centre that I'll be talking about a lot today. And then down the bottom is I spent some time at Johns Hopkins last year doing some really cool experiments with my collaborators. So you've got to have fun while you're doing it. But the other half of me is also I'm extremely passionate about my sport, and I like to use my research career to fund my passion for my sport. So with receiving that Eureka Prize last year, I was able to live out my dream of finally seeing all 4 major American sports in a single season. So it shows you that you can work hard and then you can play hard. And then because it is a little bit different career path than other people have had, I also have been a professional athlete. So I played professional field hockey in Belgium during my honours year. And then 4 times over the last 8 years, I've represented Australia in ice hockey at some world championships and won a couple of golds. And if nothing else, sport is a really good way to get out any aggression that when your experiments don't go so well. But more important for this talk today is sort of, I'll also just give a little bit of career context because again, I still haven't followed necessarily the traditional path to where I am today. So I did start off at the University of Adelaide, and this is where I transitioned from considering the largest problems in the universe and have 2 degrees in astrophysics, and then ended up in my PhD working with fiber optics and lasers to try and build biosensing devices for protein detection in cardiovascular settings. But then because I don't like to do things in the traditional way, I then completely jumped field. I joined the University of Sydney in 2017, where I've been till now. And I am working in the field of X-ray imaging for medical purposes, specifically, focusing things on interventional radiotherapy, anywhere that needs a cone beam pretty much. So I've been fortunate enough to secure a series of fellowships, working my way up to most recently being named a University of Sydney Robertson Fellow. I've been part of over close to $8 million in grant funding. So this is including especially our research group also just received a synergy grant from NHMRC looking at cardiac radioablation and trying to bring that to the fore as a clinical solution for arrhythmias. And then, as was mentioned, I've also been fortunate to win some prizes. So this really just puts in a bit of perspective where I've come from and where I am now. But again, a little bit more exciting for today and relevant is looking at the research programs. So my current research portfolio spans 2 major programs. So these are what I'm calling interventional imaging and then adaptive imaging. And so whilst they have started off as quite separate programs, hopefully we'll see by the end of the day that they're actually coming together to help feed and innovate in each space. So within these two programs, there are three main pieces of equipment that I do most of my research on. So first up, and what will be the focus of today's talk, is a robotic imaging system. So here you can see we have the X-ray source down the bottom and a detector up the top. And in a traditional fashion, this is just going to rotate around the patient table, generate both 2D and 3D volumetric images, and then allow the surgeon to continue on with their procedure, be it guidance, be it procedural verification, things like that. In the adaptive space, we have two pieces of equipment. So the first is a linear accelerator, or a LINAC, typically used for radiotherapy treatments. And here, all my work is to do with the X-ray source and the detector, and not so much with actually the treatment beam, but sort of getting ready for treatments and things like that. And then the final piece of hardware that I do work on is a standard CT machine. And again, though, in the context of treatment planning for radiotherapy and moving into cardiac radioablation. So focusing in on the interventional to start with, there are four main projects or areas that we are trying to innovate in and to work on. So these are cardiology, neurology, orthopedics, and radiology. And we're always also trying to expand out. So again, if there's anyone on this call who is interested in or has any other ideas in this space, please reach out. I would love to get into contact. So then in terms of looking at what those projects are within those research disciplines, we have some of the highlights that I'll go through today. So we first have a technology called Acrobeat, which stands for Adaptive Cardiac Computed Tomography. And this is an adaptive cardiac imaging protocol. So this is about trying to move the machine to the patient. In the orthopedic and radiology space, we then have specific projects targeting metal artifact reduction, extending the field of view, incorporating some 3D printing, as well as looking at some weight-bearing imaging. Now, yes, typically that's not actually be done in an interventional setting, but it's looking at machines like this robotic imager and really trying to push them to their limits and sort of think outside the square in doing so. On the adaptive imaging side, we are the disciplines that we're really trying to target are radiotherapy and cardiac radioablation. So on this is again all around either the pre-treatment patient alignment, so getting ready for these procedures once they're on the treatment table. And these are projects that cover a technology called ADAPT. So that is where you've got a respiratory adaptation going on to the image acquisition on that patient table. And that's just finished a clinical trial recently testing this for patients, lung cancer for patients, and we also are about to license that technology. So hopefully soon that will be available to a lot of patients worldwide. And then one that I have dubbed for the moment Adaptabeat, which is the combination of Acrobeat and Adapt. But basically it's also just trying to give both cardiac and respiratory motion management solutions. So looking into see if we can do imaging where we're taking into account all the thoracic types of motion that are going on during before a treatment. And then on the CT, in terms of treatment planning, again, we have two main technologies. We have Care CT and React, and these are just almost the CT versions of Acrobeat and Adapt. So again, I'm not going to go into too much detail of these today, but just giving you that taste that, again, if any of this is of interest, please contact offline. But again, it's just saying that we can adapt these big pieces of hardware to whatever the patient is doing, and specifically, around their motion of breathing and beating hearts, we can get and improve the image quality. And then, as I said, as the programs start to bleed back into each other, so we can then also start to use all this, resource that we have in that radiotherapy space, and that has gone a lot further down the clinical translation pipeline, and use that to help innovate in the interventional space, which hasn't yet seen as much dedication to improving the imaging for specific clinical applications. So in terms of the current project that I'm actually going to focus on and chat to you about today, we're going to try to look at 4, depending on how long I talk for. So the first one is actually bringing the adaptive imaging space into the interventional room, focusing on 3 main areas. So we have the carotid artery. So we're looking at arteries that are affected by motion, because that's often a problem and a challenge for these interventional procedures. The heart, so looking at the heart as a whole, and then looking at any procedure that's in the thorax and when we've got respiratory motion that we need to deal with. The second one is extending the field of view. So that is also another challenge for a lot of these robotic systems. You can have reasonably good image quality, but it's going to be over a really small area and be really quite focused. And again, as we push out into new disciplines, that might be fine for if you want to just capture the whole heart. Great, you can do that. It's going to look nice. But what is if we actually need to do a procedure that runs the length of the spine? Can we provide the same sort of image guidance in those scenarios? And what do we have to do to actually achieve that on a robotic system? Also want to cover some metal artifact reduction, because again, this is a perpetual challenge for any X-ray imaging. As soon as you put metal into the field of view, you have these big nasty artifacts you have to deal with, and it makes it difficult for the clinicians to make a clinical judgment or guidance based off of that. So again, there are a lot of techniques to help us do this outside of the interventional room. But again, it's about seeing if we can bring those technologies into the interventional space and have all those decisions made there and then in real time. And then hopefully I have time to touch on some of our sort of slightly left of center, not traditional imaging applications, is tying this into 3D printing and how can we use the images that we're getting to help continue to bring down the risks associated with surgery. So looking into, can we help guide procedures with 3D items that we've made from the images on a system, a robotic imaging system. So the facilities where all of this research takes place is lovely situated at the Charles Perkins Centre on the main campus at UCED, and it takes place in the hybrid theatre. So this is a picture of the hybrid theatre, and you can see that that's our robotic system, and sort of it is a full replication of a state-of-the-art theatre that you find at the hospital, but we have the great benefit that is purely dedicated to research and to innovate on. Now, what makes this an extra special piece of equipment is that working closely with Siemens Healthineers, who is the company who manufactures this type of robotic system, is that they have given us an extra bit of hardware that allows us to fully control the motions of the system. So I can simply type in on a command line and tell the robot how to move, when to acquire, full control of the table as well. That's a robotic table. And so this gives us a platform to actually innovate on. And this is the only one in the world outside of Siemens themselves. So no one else can have this type of access. So this is a real, very unique piece of equipment that we get to use. So throughout this presentation, I will just simply refer to this as the TACS, which stands for the Test Automation Control System. So that's that additional piece of hardware that actually gives us this access. As I said, it's just a few simple lines of code. Don't want to make myself redundant, but it's actually not that difficult to control this and have a bit of fun as shown in this video. The one drawback is that for safety reasons, because when you do use this extra bit of hardware, all the clinical certification gets removed because you can do anything with the system and you can get it into some really bad positions. So to try and help limit you with that, the rotation speed of the system is put down to 20 degrees per second, whereas in a clinical situation, it can spin very fast. You're looking at about 90 degrees per second rotation. So it means that for some of our applications, our scan times get longer than they would clinically. And that can be sort of sometimes a deterrent when you're talking about this to surgeons. But so therefore, this represents all the work today is that at that very lower limit of what is possible with this system. So even though it's a world unique and this is the best that anyone else can do, we know that with further buy-in from Siemens or other industry partners, we can keep pushing this further and further. So this is just sort of the very proof of concept. It is a bit of a rudimentary system, but we can still do amazing things. So let's dive into some of the actual work, and we're going to start with the adaptive imaging. So again, just putting into context, this is sort of where we started back in 2018, and we were targeting, applications in cardiology and neurology because they are probably the biggest users of theatres like this in hospitals to date, and they really drive and love the 2D fluoro imaging. And so now we're trying to come in and bring volumetric options to their imaging. So again, just a bit of our motivation is that basically there's very limited feedback between what the patient is doing and how the image acquisition is currently occurring. And that if we can bridge this, we can make these imaging modalities more useful for the surgeon. as well as, always looking into ways to lower the radiation dose. So can we get high quality images, but a lower dose, allowing more frequent imaging during a procedure, and or then considering the health of everyone else in the theatre. It's not necessarily just about the patient, but about these surgeons and nurses and the whole team that have to be in these procedures day in, day out. So to start with, our first two targets were the carotid artery, looking at pulsing arteries under pulsating motion from the heart, as well as looking at the heart itself. So our solution is to try and flip this equation around and make the imaging hardware do all the work. So can we prospectively gate when these acquisitions are going to occur? So we're really putting down that imaging dose to the lowest possible by only having exactly the data that we need. Can we have this adaptation in real time? So again, it doesn't matter what the patient's doing. If the patient heart rate increases or decreases, we can account for this. That also might help reduce any dependency on drugs to control heart rates. The patient can be as they are. And so then we can have that real personalized image acquisition. So if we actually look at what is currently available, that will help us see how we've innovated and tried to improve on this. So let's start with the carotid arteries, this sort of quote unquote simplest case. And so here, if we look at, say, what the artery would do over the course of the scan, one scan is going to be a simple, straight, circular gantry rotation where projections are required at set frame rates, regardless of what is going on in that carotid artery. So whilst this acquisition is only 4 seconds, that's a lot of time to have a lot of cardiac motion and blurring in your artery in your image. So this might make it difficult to precisely measure what size stent you need if you're fixing an aneurysm or something like that, or it just adds that more uncertainty into it. Similarly, if we then look at how we image the heart, we have a slightly more sophisticated option. So here they will retrospectively gate. So this means that they are actually going to watch what the ECG is doing and try and reduce dose outside of where a specific window you want to look at. So you might pick systole or diastole depending on exactly your application. So maybe when the heart is quiet, that's when you want to image. But then you're going to go back and you're going to throw out a lot of the data that you don't use, but you've still exposed the patient and everyone in the room to that extra radiation dose. And this is quite a high radiation dose. So to actually then get a good image, because you're throwing a lot away, you need to repeat these sweeps multiple times. So it's no longer a single sweep. It's coming back and forth to make sure that our entire imaging space is covered. And then because of all this, they often just aren't used clinically because they go, oh, it's not worth it. There's too high image dose. I'm not going to get a good enough image. And there's a lot of radiation. So we want to try and innovate on this and give a better solution so that this can be a common practice in applications in cardiology and neurology. So this is where Acrobeat comes in. So here, this is all about adapting the hardware to the patient. So if we go back to our simplest case, we'll go back to that carotid artery case. We have our carotid arteries. We're going to focus in. And so if we look now, we've still got our same motion profile and the ECG signal. But this time, as the gantry is rotating around, we're only requiring at the exact spot that we want to. So therefore, we're going to drop our imaging dose down to the minimum possible. We're also going to be monitoring for any changes, and so we'll either speed up or slow down the gantry as required, being considerate of that live data coming in. But we're still going to hopefully have an image that is just as high quality as the conventional scans, but without all that motion to contend with. So if we take our carotid artery, and in order to show the first proof of concept of this technology is that we built a little single carotid artery phantom. So here it is. We just have a Perspex test cell that has some fighter gel sort of to create a barrier for the tubing to push out against. And so if we actually pump water or iodine contrast through here, you can see under fluoro that we do actually have a pulsing that's going on within that little artery. And so this is, it actually is following a human measured artery contraction, so just trying to get that realistic motion as possible. I definitely learned early on that whilst it looks really cool that we decided to dye the water and iodine mix red when when one end burst off, and then the whole hybrid theatre gets covered in very sticky, very red material. It's no longer a good idea because it's pretty obvious who made the mess. But this is really cool that we're actually then sort of getting back to sort of being able to show, you know, if we've got an artery and it's pulsing on the right conditions, what's going to look like when we actually apply both the conventional and acrobeat scans. So that's exactly what we did. So here is a snapshot of that 3D reconstructed volume. So this is a volume acquired with all that motion in. On the left-hand side, you can see the acrobeat scan, and on the right-hand side, you can see the conventional. And just even at first glance, you can see that there's a lot more motion blur around the center of the tube in that conventional scan than there is the acrobeat scan. And if we look at some of the stats up in this right-hand corner, we're looking, so that number of projections is a surrogate for our X-ray dose. So again, our acrobeat, we've over halved the amount of dose that a patient might receive. Now that scan time is very long, so that's to do with that slow gantry rotation. So we can definitely look to bring that down in the future. So it even shows you that within that 4 seconds, you're getting a lot of motion that could potentially be quite damaging to your clinical decision making. So yes, there's a 60% reduction. And then if we have a close-up, of that actual artery, and we measure the difference in our width, you can see that actually just accounting for that, the motion that is happening in the artery, we can reduce a measurement by almost 2 millimeters. So again, this definitely represents a upper limit to the amount of motion. You probably wouldn't see this much motion in a human, but it was the fine tuning that we could do of the motor. This was sort of the closest we could get. But again, it's a really good demonstration of this. And if we look at the actual artery width number, I apologize, I actually didn't have it listed here. The artery is only, the tube was 8 millimeters wide in diameter. So whilst we haven't fully eliminated the motion, there's still about 0.7 degrees expansion in millimeters expansion of the artery. We've really reduced that down back to almost what it is with no motion. So this again is very promising that that then can be a more useful tool for the surgeons or clinicians to use mid-procedure to assess how things are going. So today I will actually skip the cardiac work and go straight into the next level because it's a very similar application. So instead of just having the artery as our imaging target, we can move to a more complex thing and have a heart structure. But we see very, very similar results. But what's a bit more exciting now is that we also want to expand out and can have that multifaceted approach. So have both a cardiac adaptation as well as a respiratory adaptation to take into account any respiratory motion, and have a fully dual cardiac respiratory motion mitigated imaging. So in order to do this, because respiratory motion is management is not something that is typically done in the interventional room at the moment, it's not really a consideration, but we can build off all the strengths that we have in radiotherapy, where respiratory motion management is a standard and a must for all thoracic applications. So if we look at what changes we need to make to the experimental setup or the the hybrid theatre in general, it's pretty much the only addition is actually adding something that's going to monitor what is happening with the respiratory motion. So in this case, this is a depth sensor. This is again something that's commonly used in radiotherapy, where it's virtually just going to monitor the chest motion of the patient, and that gives us the surrogate for the breathing motion, that internal motion that's going on. Also, what's really exciting about this work is we're bringing new collaborators into the fold, which is always a good thing to do. So the main ones here include the University of Victoria in Canada and the University of Pennsylvania in the US, and maintaining our strong collaboration with Johns Hopkins University to bring this to light. This also is going to allow us to branch out into new disciplines within the interventional room. So we have targeting oncology, radiology, and looking at when we've got biopsy needles or ablation probes, anything that's where we're going to guide some bit of hardware, and you're going to be in the thoracic cavity where you're dealing with motion. We want to give better image quality for those procedures. So to start looking at this, the first thing you need to do is actually have something to image, which can be quite tricky in this space, is to actually get something that's realistic in anatomy that is also going to move in a realistic way. So to have that deformable motion, we don't just want a rigid motion that doesn't quite replicate exactly what goes on in our human bodies. So luckily, my collaborators at the University of Victoria have designed this really cool phantom. It's called Casper the friendly phantom. And Casper actually breathes. So the first step of this work was changing him from an upright demonstration of breathing to actually be applicable to be used in the hybrid theatre. So here's an example of Casper set up, ready to go. But if we take a bit of a closer look at what this looks like, so you can see that the phantom here is actually breathing, it's moving in and out. But what this is going to look like is, we look at this on fluoro, you can start to see down here that we have this motion being driven by, we're pushing back and forth this diaphragm plate, and that is compressing the lung mold, the lungs that we have sitting in this chest cavity. So this, unfortunately, I should have updated this little clip. So this is one of the very first experiments where we can see that there is this quite large gap between where the diaphragm is making contact with the lungs. We have since rectified this so that we have full contact, and so we're getting more motion, because you can see there's a few little targets up here that I'll explain in a bit more detail, but there's not a lot of motion going through them, which is not representative of a real breathing cycle. So to help make this a bit more realistic and focus on the applications that we want, let's take a little bit closer look at the Casper phantom. So here we go. So here is a look where you can see the diaphragm plate, and it's pushing up against the lungs. And so just to have a little bit of fun of how we actually made these lungs. So these lungs are just made from a expandable foam. So this is Professor Magdalena Basilova-Carter was over from the University of Victoria. So we 3D printed the molds to get the realistic lung shape. We mixed all the materials. Neither of us know much about chemistry, so definitely had a bit of fun doing this, and it means that then we have a squishy foam lung that we can do. And also what's exciting is that during that molding process, we can start adding some targets in here that are both, simple, so like a spherical tumor. So again, this is, we know what the size is, we can track how it changes over time. But we also have like something like an irregular tumor. So this has been a clinician has contoured a real patient CT. So this is a PTV of a real tumor. So again, it gives us, how we are imaging irregular objects. We can also then start to push into that, the application space of, as I briefly mentioned, of having other metal hardware in and around. So this just has a thin metal wire that's meant to be a surrogate for like an ablation probe or a biopsy needle. I will get into a bit more detail because that ties into the metal artifact reduction later on. And then we can also have some fun and print something that looks like a bronchial tree and see how that whole thing moves. And again, can we have our imaging techniques good enough to adapt and eliminate motion over something that has a lot of structure and a lot of intricate detail. So unfortunately, this work is on the cusp of being ready to show. So I'll just have to show some very preliminary data, but this definitely will come out in the next few months, the work that we're doing. And just down here, we're just showing that we are then able to drive that bottom diaphragm with both a constant sinusoidal, but also pass patient motion traces through to get realistic breathing properties. So here's just a snapshot of the whole setup and acquiring a conventional scan where we've just got that single rotation of the system while our patient Casper is on the table. And so today I can just show the results of those conventional acquisitions. So this still gives you a bit of a taste of what we eventually might look for. But so on this left-hand side, the left-hand column, the first one I'm going to look at is what we call our ground truth. So we've got no motion in there. So here, in the top, you can see two spherical tumors of different size, and then one of our irregular tumors. So again, we wanted some very close to the diaphragm to get the most motion, and then put one a little bit higher up that should have a gradient of less motion. Down the bottom is in this set of lungs, we have, again, one of the irregular tumors, but this time we have the metal wire, and you can see some of the metal artifacts around even in the stationary position. And then you can see a little bit of the bronchial tree. There wasn't a great plane to get the entire thing in there, but you can start to see this extra structure. Now, as we move across towards the right, you can see what happens in the conventional acquisitions that don't have any way of compensating for the respiratory motion, the type of artifacts that you're going to see and make it really hard to make any clinical decisions. So again, even in just a sinusoidal, very regular breathing trace, you've completely lost the shape of that spherical tumor. It's really hard to make out what's going on. And that's the same replicated in the patient breathing traces. Although surprisingly, this trace 3, that must have been a reasonably regular patient trace, has done quite okay. But still, in general, you want you want a personalized approach, so not a one size fits all that maybe it's going to work one time, but 1 out of 4 is probably not great. And then similarly, you can see we start getting a lot of ghosting and other artifacts around the bronchial tree. So again, it shows that when we've got structure, we need to help compensate for the motion there. And then especially when we've got the metal as well, that just makes our problem twice as hard, because now you've got these really funky metal artifacts that would be there in the no motion, but as soon as you add motion, that gets even harder to deal with. So hopefully maybe one day I can come back and give the updated talk of how we compare when we apply our adaptive respiratory imaging techniques, and hopefully we can bring this all back so they virtually look back to the ground truth. But for now, I unfortunately just have to tease that and leave that for next time. The next challenge that I want to introduce to you is extending the field of view. So we're going to also fully change disciplines. And so this is typically going to be targeting something to start with, like orthopedics, where your surgical fields can easily get quite large. So again, our motivation here is that, at the moment, not a lot of procedures in orthopedics will happen on a system like this. But if they did, we already want to start preparing for being able to give techniques that are specific to the type of procedures that they would occur. And so again, a lot of orthopedic procedures are based around placement of hardware. So we want to make sure that that's done accurately. We want to be able to verify the procedure in room. So that's going to help lower the chance of a secondary corrective surgery if something is spotted post-op in imaging, which unfortunately does happen a lot right now. And then also, excuse me, shorten the procedure times, because this will also benefit patients greatly. The shorter time that you're under anesthesia, the better it is for your recovery and all that stuff. So, but one of the biggest challenges is that how can we actually capture an entire long anatomical site into a single 3D image to actually get any of those benefits? So, excuse me, if you look at a typical spine, you're only going to be able to currently fit in a handful of vertebrae, which again is not really suitable for a lot of the procedures where the entire spine might need to be stabilized. Additionally, a lot of our anatomy is wide. It is wide and long. So say if we consider the lower anatomy, maybe in a trauma situation, even just taking the hips, for example, it can be really difficult to actually capture that in a single 3D volume. So again, if we look at these black volumes, these are sort of representative of the conventional field of view that we currently have. And we want to see if we can actually extend this and capture both those sites in single volumetric images in room. So in order to do this, we need to think outside the box and think of new ways to actually control and acquire the images with these robotic systems. So for the first one, we were just looking to extend the longitudinal field of view. So this is the field of view down the table. We can start drawing from acquisitions like a CT that often occur in a helical nature. But we have to take into the considerations the restrictions of the system. So our robotic C-arm can't indefinitely rotate in the same directions like a CT can, but it can rotate 400 degrees, so it can go over one full rotation, and then we can bring it back. So if we can sync these rotations, so forward, backwards, as well as a table translation, we can start to image the whole way down the patient table. So I won't play this whole video, but because it is a bit slow. So what we can see here is that we have a pig cadaver on the table, and we're going to try and image this entire spine. So as the C-arm is doing its rotation, you can start to see that now the table has started translating away from its original position. And as we reach the end of that first rotation, we're going to reposition, and then we're going to rotate the other way and continue that table translation. So all throughout this, we're imaging, we're acquiring our images, and then when we reconstruct, we're going to have a nice single volume that covers the entire width, the entire length, sorry, of our required surgical field. So if we look at an example for when this might be applicable, so we'll take the thoracic and cervical spine of that pig cadaver. And what is if we need to perform a laminectomy in the cervical spine? So that's when we remove parts of the lamina to release pressure and in the spine. And we want to do a pedicle screw fixation from T2 down to T12. Well, this is going to require a 58 centimeter field of view. And so we actually want to, can we provide imaging and guidance over that entire surgical field? So we know preoperatively we can. So if we pretend, well, we are actually going to go and do this surgery, but I forgot this one's actually sheep. So we now have our sheep patient on here. And so if we're going to plan out this procedure, we're going to take a CT and we're going to have as much length as we want. Here we've got a field of view of 106 centimeters. So that's definitely capturing all of the bits of the spine that we want to see. So the surgeon can go plan off this. But then when we get into the operating room, one, we want to make sure that there's been no anatomical changes since planning and performing the surgery, and or the patient might be positioned slightly differently. So then if we apply that multi-turn reverse helical imaging trajectory where we're going back and forth around the patient table, we can try and get close to that same anatomical coverage. So now we're able to have 80 centimeters in the interventional room. And again, we can clearly see here, so up here's our cervical spine, and then we have our thoracic spine covering from our T2 to our T12. Now, if we were to do this with the conventional acquisition in the operating room, what we're going to have to do is we're going to take a whole series of conventional scans and stitch them together to get that same coverage. So one, this is going to be extra imaging dose because again, each of these individual scans have just been optimized to give the best image quality for the specific that specific region. And then unfortunately, this is what happened. So this is absolutely not planned, and I'm still a little bit annoyed at myself that I did this. But as I was manually moving the table between those 6 scans, I missed a little bit. And so again, this is a problem with this, that's not an automated process. If you want to do this, you have to do it manually. I thought I had everything lined up. It wasn't until I got back to my office and double checked the data. Turns out that I just missed this little bit of the sheet. Luckily, that was outside of our the planning or the surgical field of view, so that wouldn't have actually been critical to the procedure. But it shows you that we need a better way of doing it, so that something like that multi-turn reverse helical offers that solution. We then can consider post-operatively. So again, that gets us set up for the procedure, but we also want to give them that option that say, the current ways to come back and do a CT post-operatively. And this is where you then unfortunately identify if anything didn't go as you'd planned. You have to get back in there and have another surgery to fix it up. So again, this is just showing that we can again do this even with spine hardware in there. So we're overcoming some of those metal artifacts in this multi-turn reverse helical. But again, it shows that we've got the same coverage, similar image quality in terms of, yes, nothing is still going to be as good as CT. You just have so much contrast, around the bone, and you get really good soft tissue contrast here. So again, our bony anatomy is fine. We have reasonable soft tissue contrast, but again, we could always do slightly better and then keep pushing towards the standard CT. If we come back and compare this to the conventional scan again, you can see this time I didn't have any gaps, so I did capture the entire field of view. But again, you still get a lot of overlap and overdose of these regions. So again, it's just about optimizing a better way to do this. So this is exciting that we can bring the same sort of, the benefits of a CT, which is it's the length and the coverage, we can now start doing this in the interventional room. Since this manuscript was published, we've even pushed it out to over 1 meter. So this is an 87 centimeter field of view, but we now can go over 1 meter. My spine is not that long, but I hear that there are a lot of people out there who are a lot taller than 5'0". So this gives us an option that it's, again, we're not limited by the patient's size. A little bit pressed for time, so I will keep carrying on though. So as I said, another challenge is also trying to look at when we have a wide patient. So if we actually take the multi-channel reverse helical and use that as our base, so that we're going to keep sort of the concepts that have helped us get the length in the imaging, but also then we're going to extend out laterally. So if we take one of our rotations that we're doing and split it into and add a table translation between those rotations, and then again come back and forth as we're moving down the table, we can start to have both the benefits of the long field of view as well as the wide field of view. So the conventional acquisition in this case, there is a wide option that allows you to start to look at, say, getting in the entire hips, but then if you do that, you're going to lose your lateral coverage. So again, this just shows that the conventional acquisition does have these two separate arcs for that little bit of translation. So that is something that people are clinically, are currently using and are happy to do. So we're just going to extend that down the table and again, automate the entire process. So this is a snapshot of a very sped up version of how this acquisition works for us. And you can see the same sort of concepts that, we're doing those two little rotations and we're working our way down the table, imaging the entire time. But so this is going to allow us to have a single volumetric image that is going to cover from the hips to the ankles. Now, again, you totally might question, is this even necessary? That is definitely potentially up for debate, whether anyone would ever use something like this clinically. But again, it's just showing that there are these capabilities and we can innovate and we can sort of try and find solutions. Whether anyone ever actually uses this is another question. But, when you want to give people the option. So the case that you could potentially see this being useful is in trauma cases. So let's take our little skeleton here, and unfortunately, they've been in a high-speed vehicle accident. So they have multiple trauma to multiple sites in those lower extremities. If we take a conventional scan, as I said, we're going to say potentially be able to just capture the whole hips, but we need that entire length. So if we go down, in this case, we'd need 9 conventional scans to get our same, the whole piece of anatomy in, and this is going to add up pretty quickly. So to actually do this on a conventional system, it's going to take 25 minutes, which is way too long for any type of imaging, and especially in the interventional room, no one is going to stop for 25 minutes to do this. And you have an extremely high projection count, so that's a lot of dose to the patient. So again, also not ideal to do this conventionally, but if we compare that to what we can get with the dual isocenter. So again, here's just a showing of the conventional all stitched together nicely. Didn't miss any parts here, so that all looks really good. You can see though that there are still a few slight stitching artifacts that again, in general, not too much of a problem, but if one of those is going to fall at a critical point, that could degrade your clinical decision making again. If we then compare to our continuous dual isocenter, you can see that we're pulling back, all of that detail. We can nicely see all those bones within this phantom. There's a slight drop of image quality there at the hips in that top axial plane. But if we compare sort of our lateral coverage, we've got the same. We're almost getting 1 meter and we're about 45 centimeters wide. And we've dropped that scan time down to 5 minutes, which is still quite long considering all our slow constraints on the rotation. But we've also halved that imaging dose. So there's still plenty of scope there to push that imaging dose down further. But we've got these really nice images. And so we've got our entire area that we want to see in this single image that we can start using. So just briefly in terms of image quality, even though visually they do look pretty similar, we can sort of play that out in these metrics. So if we look at our contrast to noise, we have a very similar between so our bones and that background material. Our structural similarity, again, is very, very high, which aligns with what we're seeing, that we're getting back some of those fine details in some of those bones, down in that feet. And that, we only have a bit of a mean deviation across the whole thing of about 7%. And probably a lot of that is driven by some of the artifacts you can see right at the edges of the field of view, so up in that hip region. Yeah, but this also then, whilst that might not be super practical and have too many applications by itself, what we want to do is start combining this with some of our adaptive work and look at situations where you might have a long piece of anatomy, hey Marcus, and you have long and motion involved. So again, we're looking at combining how we're controlling the acquisition as well as our length. So again, this is applications for something like a neurology, so you might want to actually image the entire aorta, or the aorta all the way up to your carotid arteries in a single motion-free but long volume. And again, this has been brought to our attention that is something that an interventional radiologist would love to have that doesn't exist right now. So being able to do that would be awesome. Now, I can see my clock is ticking up to 45 minutes and I have a ton more to get through. So unfortunately, I'm going to be this person and just push right to the end, because even though there's some great stuff, I always miscalculate how much I have to show off. But basically, I want to leave you with, oh, too much. There was no chance that this was ever going to make it. Okay, is that also just not wanting to limit yourself to those in-room applications. And so we want to make sure that anything that we're doing is also applicable to another range of hardware. So we're currently working on that Artis Pheno, which is that interventional system, which again is focused in the operating room. Recently, Siemens has also brought out another cool robot that has 2 imaging arms on. So my collaborators at the University of Pennsylvania have access to this bad boy. So again, to see if there's other ways that we can push the limits of those capabilities and take advantage of our 2 imaging arms. But that's still in the operating room. They also have some of these cool robotic images that are typically found in emergency settings. So again, this is where you've got control. You could have control of the detector and source on different arms, giving you much more flexibility to image around the patient. So all the technologies that I'm developing for the operating room, we also want to put into an emergency setting for diagnostic, but then also as an outpatient setting as follow-up. So cover that entire pipeline of imaging. And then finally, we also want to make sure that we're pushing down to these more simpler systems. So we're so lucky that, in Australia, there are a number of these robotic systems in our hospital system that we can be benefit of, but they're extremely expensive, and a lot of rural, remote, and even lower socioeconomic countries are never going to have the chance to have access to that. So we're looking to also make sure that all those technologies are applicable to these simpler systems that are much cheaper and much more accessible everywhere. I will just finish with this final slide to say that I'm so fortunate that I get to work and lead such an amazing team of researchers, both here in Australia and all over the world. And there's definitely a lot of thanks to everyone behind the team to get up a lot of these results. And you have to believe me, the other half that I wasn't able to show you today. And I will end there. Thanks, Marcus.
Sorry to cut you short there, Tess. Fantastic presentation. So I'm sure everyone will join me online with a round of applause for a wonderful presentation. Thank you very much, Tess. And I'd like to open up to questions from the audience. You can either raise your hand in the participants or just jump in on the chat. And I'm happy to take any questions for Tess. Tim has a question. Tim.
Hi, Tess. Great talk. Thank you very much. I just wanted to ask you, I imagine that these various modified scanning protocols, as well as taking into account motion, patient motion, requires some modification in the CT reconstruction software.
Yes.
So I wonder if you have this expertise in-house, because we might be quite interested in maybe asking advice or maybe collaborating in this area later.
Yeah, oh, definitely. So yeah, that is one of the biggest challenges. And so I didn't touch on it as much because I lead all the acquisition. But in terms of that reconstruction, because we 100% need to do that all ourselves, it is not compatible with that inbuilt system. So here in Sydney, our primary contact is and I can follow up offline, is Owen Dillon. So he is responsible for doing all the motion compensated. So anytime we've got motion and adaptation in there, he has written some brilliant reconstruction codes that help with that. And then overseas, so for anything else that's the outer plane, so the long field of view, if I've got it to the metal artifact, all that sort of non-circular acquisition, we then have that expertise at Johns Hopkins. But again, they are always looking for more collaborators as well. So more than happy to chat offline and see if there's something that we can do together.
Excellent, thank you.
Yeah, I believe it's not easy to get access to the raw data from these CT scanners. So obviously you've got good partners there in Siemens.
That's right. That is also a massive challenge. So yeah, very thankful that Siemens entrusts us with that. So that is definitely a key part of the collaboration is also getting that raw data, because there's a lot of challenge if you're reconstructing off the process data that everyone has access to. You're never going to be able to have as good as reconstructions as we can get. So definitely that helps a lot.
Thank you.
Fantastic. Are there any other questions from the audience? Maybe I can throw one in while the audience is thinking. Very simple question. I'm sure that this will be trivial for you, but having never been involved in interventional radiology myself, I'm just wondering, since a CT scanner can obviously do like a whole body imaging already, and some of them probably have lung motion things built in possibly, why is it so difficult? Why can't they just use a CT scanner in the clinic already?
Yeah, definitely. So there are those handful of examples of where you have CTs integrated into your operating theatre. In which case, yes, you then have all the benefits you have outside, inside. That is a very rare situation. So just unfortunately, if that was more widespread, again, that would be fantastic. And in an ideal world, that would be the quality of care that every patient is receiving. It's just that they're expensive. It can be a little bit more limiting to work within those parameters in terms of doing procedures whilst you're either imaging and stuff like that. So it's a bit more of that practical constraint, because yeah, 100%, a lot of the work that I'm doing and leading is like it's a solved problem if you had the right hardware and stuff like that. So yeah, I would love to see more CTs in operating theatres, but it's just unfortunately at the moment is not ubiquitous.
Yeah. Can you give us a ballpark idea of like the cost of the low-end C-arms to the ones you've been using to a CT system?
Yeah. So, and that's what I said, probably I say cheaper. I actually don't know what those mobile systems retail for, but they would be a lot less. But say the robotic system that we have in Sydney at the Hybrid Theatre, that was a $4 or $5 million install. So that's a lot. And the same CTs are probably in that sort of $2 to $3 million mark, because they are used for so many other applications that a lot of hospitals will have multiple CTs and stuff like that. Again, in that specific interventional suite, that price tag is probably again higher to have that specific setting. But I'd probably range those mobile systems probably in the hundreds of thousands to $1 million. But so definitely it is cheaper. But I'm sure probably, as we all know, as soon as you slap that medical tag on there, it's not going to actually be cheap.
Yeah. Okay. Fantastic. Thank you. Don't see any more questions coming up, but has anyone got any more for Tess? I guess it was a very clear talk. So
that or it is Thursday afternoon.
Tim has another one. So Tim,
yeah, fantastic.
Back. If there are no other questions, I just wanted to ask Tess, what kind of radiation doses you're considering are considered acceptable in the context of your imaging scenarios?
This is very true. That it's hard to sort of put a number on it, because I guess when you look at the different disciplines, they're more comfortable with different amounts. So say when we look at some of our applications for the cardiology or the radiology, where they're very sort of familiar and are often using fluoro and other guidance, so they're sort of more accepting that then there has to be some sort of radiation dose. So they're less scared off they're less worried about how much fluoro and CT they're getting. The cone beams don't have quite as high radiation dose as the standard CT, but again, if you're doing multiple of them because they're not quite right, it's going to add up quite quickly. Whereas compare that to, say, a lot of the work that I'm doing with the orthopedic surgeons and in orthopedics, because that imaging isn't as comfortable, it's not the like sort of standard of care, they're much more worried and are like, no, like it needs to be minimum, like maybe we can only image once, or stuff like that. So it is that sort of, the different disciplines have that sort of different threshold. But I think as things are trending towards having more and more imaging available, and I think once we can show the surgeons that, hey, yes, like you can't just image all the time, but the benefit that you can get can be traded off for that radiation exposure. But again, it's still trying to keep it down to the levels of like a CT scan or something like that, because again, you don't want to have be exposing the surgeon stuff to that for an entire career.
Thank you.
Fantastic. Well, it doesn't seem there's any more questions coming through from the audience, but I want to thank you again, Tess, for a fantastic presentation. So another round of applause. Thank you very much.
Thank you very much. It's been great.
Yeah, it looks like you're doing some very exciting work there over at ImageX Institute. And I guess I'd like to wish you on behalf of everyone all the best for all your future endeavours and all the exciting work that you're getting done, and hopefully make a big translation in interventional radiology. So
thank you so much. Yeah. Have a great day, everyone.
No problem. Thanks very much, Tessa.
Bye.
We'll see you all next time.
Thank you.
Bye.